Okay. So who has any questions about what we've done thus far? Any questions? Zero? Not a one? Okay. So if that's, can't hear you. All right.
엄마 수업 중이야, 지금. 수업 중이야.
All right, go ahead and mute that if you don't mind. All right, so let's start with a couple of definition terms, medical terms. So what is a thrombus?
Blood clot.
Say that again, please.
A blood clot?
It's a blood clot or clot, okay? What's the difference between that and an embolus?
Embolus. The embolus doesn't it like travel through?
A clot that came loose. That's what, thank you, Marie.
Yes, that was it.
So basically, it's a moving clot. So if you have a clot somewhere in the body, that's a thrombus. If it travels to a different location in the body, it now becomes an embolus. Okay, so you can have someone have a deep vein thrombosis, which means it's in one location, lower extremity, primarily in the calf area, correct?
Correct.
And then if it moves to, say, the heart and the person has a heart attack, or to the pulmonary artery and they have a pulmonary embolism, or to the brain and they have a stroke, that's an embolus. So those are the difference. One moves, one stays stationary, right? So with what's kind of, sorry, okay. What is the genetic makeup or the process for which a DVT happens? There's like three different, there's a triad, Virchow's triad. What is Virchow's triad? Okay, so causes of a DVT would be someone's not moving. All right, so good, Michelle. Stasis is the first thing. So you have blood that becomes stagnant. So the valve has some type of dysfunction, or maybe the leg muscles are inactive. Therefore, the blood becomes stagnant and a clot forms. Now we have vessel damage. Good, Karina. So there's vessel damage that happens. Okay, good. Tears, vessel wall injury. What's the last stage? There's three. Increased coagulability. Thanks, Amy Lee. So those are the three things that happens, or hypercoagulability. Hypercoagulability. That's a big one, right? So you can see that in like severe anemias, malignancies, nephrotic syndrome is where you'll see that happen. So ladies of childbearing age that are taking estrogen of some kind, then they have hypercoagulability. Postmenopausal women, same thing, because they're taking hormone replacement therapy. But these therapies put them at risk for VTE. What is VTE? So V as in Victor, T as in Tom, E as in Edward. Anybody? I don't care who says it. Venous thromboembolism. Thank you, Isra. Okay, so how does smoking play a role in vessels? Does it help vessels? What does it do? It constricts, it causes vasoconstriction, correct, Amy Lee, Andrea, and Michelle. It also causes hypercoagulability. So, and it does that by increasing the fibrinogen and the homocysteine levels. So fibrinogen and homocysteine levels are increased and activating the intrinsic coagulation pathway. So that's how it starts the process in causing clots. So yes, it does cause vasoconstriction, so it makes it a lot more difficult for the blood to travel through, but it also increases plasma fibrinogen levels. It also increases the homocysteine levels, and those levels will also activate, or in that process will have activation of the intrinsic coagulability or coagulation pathway. Does smoking cause cystine stones? Not sure about that one, Michelle. But that is a good question. So I'll research that for you. So let's look at risk factors associated with DVT, deep vein thrombosis. So someone had on here earlier or typed in immobilization. That was Kay Gannon. So, like, what would make a person immobile? Okay, so we have immobility, we have surgery. Those are two causes, but let's stay on immobilization for a minute. So obesity, long flights, good. Isra and Marie. What else can cause a person to be immobile? What if you're standing on your feet for a long period of time? Illness, age. So bedridden individuals, disability, paraplegic, quadriplegic, long flights. What about traveling in the car, sitting in that same position? And we kind of talked about this in class the other day. So, when the war on Afghanistan was going on, there were several news media individuals that, as they were traveling around with the different units, they had to stand on their feet for a long period of time in the same position. One gentleman ended up with a PE because he developed a clot and it broke loose and traveled. Bed rest in pregnancy, bed rest period. So if you're in bed for a long period of time, coma, that person will be at risk for a clot. Okay, so Kay Gannon had on their surgery. What kind of surgery would lead to someone developing a DVT? Hip. Okay, so any orthopedic surgery. So if you have a femur fracture, a tib-fib fracture, all of those can definitely lead to a DVT. More specifically, femur fractures, because it's your largest leg bone, correct? Good, Kay Gannon. What else? What other surgeries besides hip? Knee surgery is still orthopedic. Pelvic surgery would fall under orthopedic. What about thoracic surgery? So any chest surgery that's done. That will fall on the thoracic, will fall under heart and lungs, anything in the chest. Belly surgery, so any specific organ in the belly. And then genital urinary, so anything in the genital urinary area can predispose an individual for a DVT. So main areas: orthopedic, chest, belly, GU. Okay, because GI would fall under belly. Cancer can lead to DVT. So, pancreatic cancer, lung cancer, ovarian cancer, testicular cancer, breast cancer, colon cancer, all of those, radiation therapy, all of those can lead to DVTs. So that's why they keep them on some type of anticoagulant. What's the difference between an anticoagulant and an antiplatelet?
If I'm not mistaken, anticoagulant it lowers the the clotting factor, but antiplatelet lowers the platelet count. If I'm not mistaken.
Okay, so how do they work in the body? So if we're using them as coagulation modifying medications, how do they work? Where's their impact?
The coagulation one, if I'm not mistaken, it works on the factors the clotting factors themselves. But the one for the platelet, the antiplatelet works on the thrombosis, like the thrombocytes themselves, if I'm not mistaken, or I may be wrong.
Okay,
Like-
so normal process when you're looking at the clotting factor, the normal process is if you have an injury to a vessel, then the vessel constricts to try to make the hole smaller for blood not to seep out, right? But when that happens, there are mediators or signals that also get sent to the thrombocytes, the white cell, the leukocytes. They go to that area and they begin to aggregate. Aggregate means clump together. Platelets clump together so that way they can form a clot. And so as enough platelet aggregation or platelet clumping happens, then the clot forms. Then you have your fibrin network that comes in and pretty much kind of tightens it up. So it kind of gives it a covering to hold it in place, correct?
Yes.
Kind of a non-medical way of saying it. So if it's antiplatelet, then when you have, an injury or anything like that to the vessel, then the platelets do not allow for aggregation to occur or clumping to occur, which means there'll be no clot formation. So what 2 lab values would we be looking at if we wanted to test our coagulation studies?
The PT and the PTT.
PT and PTT, correct. So what does PT measure and what does PTT measure?
One's the extrinsic and one's the intrinsic effect. I just can't remember which one. I think I got it backwards though.
Okay, so if we're looking at medicines, we have, Coumadin, we have heparin, we have all these different, we have Lovenox, we have aspirin. So if we're doing a PT, what is it really evaluating? The effectiveness of which medication? Your prothrombin time. So PT measures heparin. Thank you, Yodit. And then if we're looking at the INR is going to look at the PT. So that's why it's usually PT INR. Okay. The prothrombin time is going to measure your Coumadin levels. So that's what it looks at. That's what it looks at for. Thank you again, Yodit. When you're talking about PT and PTT, that's what the doctor's looking for. So, if you're on heparin, they're going to do serial blood studies, serial PT, PTTs to make sure that you're therapeutic, and that way it minimizes your ability to form clots. Okay. All right. So signs and symptoms of a DVT. How do you know a patient has a deep vein thrombosis? It's warm, the calf is warm, and it's swollen. So you have an edematous calf and it is warm, it's painful, and it's swollen, correct? That's my phone. Sorry about that, guys. They can be asymptomatic. So some can have pains, and some will have tenderness, swelling, warmth, and depending on how bad it is or how big the clot is, it may cause the extremity to become pale and cyanotic. Okay. Go ahead. Oh, that was me. Do we use Hohmann sign? What's Hohmann sign? Kay Gannon says no, so does, I think it's Shiny. Shineri. Yes, we don't use Hohmann sign. Hohmann sign used to be used a long time ago. So, and they use it a lot after women had babies, etc. But what will happen is what you would do is you would flex the person's foot. So basically flex it towards their face to kind of stretch out the calf muscle. It's kind of like what you do when you get a Charlie horse, right? So if the person had a clot, it could actually, as it's stretching the calf, stretch the area and actually loosen up that clot, and now it can become mobile. So we don't do the Hohmann sign anymore. So in the indice or the indication of a clot was if you did the flexed method of the foot, then the patient would have pain. So this is the reason why we don't do that. So if anyone tells you to do a Holman sign, you should be like, like Holman, no man, we're not going to do it. Okay. So it does cause emboli. Thanks, Ashley. So some other signs that you may see, they may have sweating, they may be pale, they may be flushed, they may have changes in their vital signs like their blood pressure, heart rate, respiratory rate, when they're having pain. What is intermittent claudication tied to? Is that tied to a venous or an arterial process? So is it we have venous, correct? What does intermittent claudication mean? Anyone? Intermittent claudication. Are you all like feverishly typing? Let me look it up. So pain when moving that's relieved at rest. So it's a cramping pain that usually happens in the calf. That's usually comes about when a person is exercising, or it can happen when they're walking. But it's not a venous process, it's an arterial process. So it's when they have pain in their leg that's associated with an arterial clot. So what would an arterial clot present as? What would be its presenting signs? Thanks, Ashley, by the way. What would be the signs and symptoms of an arterial clot? How would you know? What would be your hallmark signs? No pedal pulses. Their leg would be cold. Thanks, Marie. Cool extremities. Thanks, Kay Gannon. So their pulses could either be diminished or absent, distal to the clot. So more than likely the leg would be pale or cyanotic, depending on how bad it is, cool to touch, and the pulses will be either diminished or not present. But that's usually when they have intermittent claudication, is because they have an arterial clot. Now, you know, they can do surgery or venogram or arterial. What was that? Oh, I thought somebody had a question. They could do arteriograms, they could do surgery. Hopefully they catch it in enough time that the person doesn't lose the extremity, right? Okay. So what is PVD? What is peripheral vascular disease? Thank you, Kay Gannon. What does that mean when you hear it? That it can be arterial or venous. So this is why we're talking about DVTs, and we're also talking about arterial clots, because it's vascular and it can affect both the vessels or the veins and the arteries. So they both will impair blood flow. Thanks, Kay Gannon. So we've already talked about the complication of a PE, pulmonary embolism, right? What would be the signs and symptoms of somebody that's having a pulmonary embolism? A sudden onset of shortness of breath, that's the first thing. Increased respiratory rate, decreased pulse oximetry. Okay. They may have coughing, pink sputum. That's more pulmonary, that's like a pulmonary edema, different process. Increased heart rate, yep, I will agree with that. So if you have somebody that you think may have a PE, you know, what would be some questions to ask? Are you on any hormone replacement therapy, contraceptives? Do you smoke? Did you have any surgeries recently? Have you been immobile? Have you had any long flights? those would be the questions that you would want to ask. So what would be our nursing assessment for DVT? So we're going to look for warmth, we're going to look for tenderness, we're going to look for pain, we're going to look for color change, to see if they have any type of a palpable cord along the vein on the calf, right? And we're going to check the symmetry of the leg to see if one leg is bigger than the other leg, because that's what you would normally see with a DVT. Diagnostic studies for DVT would be a duplex venous ultrasonography. So they're going to look at the vein specifically. They can get a CT pulmonary angiograph. They're basically going to do studies to see, they're going to do an ultrasound to see if we're getting blood flow. That's their biggest thing. Depending on if they can't get what they need, then they'll go to some of the more sophisticated diagnostic studies. So how can we as nurses in the clinical setting prevent patients from having DVTs? Or just as nurses, period. What's our responsibility? So we need to get them up quicker, right? So once they're after the, I won't say immediately as they come out of surgery, but within 24 hours, we need to have them dangling their legs and potentially getting up and walking. Administer the anticoagulants. Move them frequently. TED hose, the elastic stockings, or the compression devices. Repositioning, keeping them hydrated. So these are all good ones. Michelle, Amy Lee, Terrace, Will, Ashley. So all of those are good things that we want to do. If need be, depending on some of the prophylaxis, we're going to give them, as we said, anticoagulants. They may have to have a thrombolytic to help. What does thrombolytics do? What does it sound like it does? What does lytic mean? It's a form of lysis. So it's going to break down or destroy a clot. So thrombolytics. Antiplatelets would just be basically to prevent platelets from clumping, like your aspirin. So those would be some of the things that they would do. And the other thing is those SCDs. What are SCDs? S as in Sam, C as in cat, D as in dog. Sequential compression device. Thank you, Kay Gannon. All right. Surgical procedures, they could have a thrombectomy, so they can remove the clot out, or they can have a vena cava interruption device. A vena cava interruption device would be something like a Greenfield filter. So it's a filter that actually catches clots and prevents them from reaching other places. So even if the patient does form a clot, then it doesn't cause damage. So a Greenfield filter is what it's called. And it just basically put it in, and it will prevent the individual from the clots from going to other places. So that's from a person who's constantly producing clots. Okay. All right, so let's look at this case study. Share screen. Can everyone see this case study here? All right, so do you see the difference in the leg size? Which leg is swollen? It'll be the patient's right. Correct is Kay Gannon and Jessica and Michelle. Okay, so here we would look at this leg, and then we would, obviously there's some swelling here. There's some discoloration. This looks a little bit more true to skin tone. This looks a little bit more, pardon me, more pale, more shinier looking. Yep, more shiny. Thank you, Jessica. So something doesn't quite look right. The knees, even the kneecaps are completely different. And then this looks like little spider veins over here. So We have a 42-year-old patient who has a business where they travel quite frequently. So they travel to Europe, Asia, and across the US. Many flights are a minimum of 3 to 12 hours. That should be an H. So let's just go ahead and put that in there because otherwise it says something else. After one flight, they noticed that the right leg was swollen and discolored. So she went to the family physician to be evaluated. What tests would the physicians order for this patient? Let me just make that bigger. Can you guys see that? So what test would the doctor order? Pardon me. Okay, a venous ultrasound, X-ray, Doppler study, CT, Good Kagan and Jessica Yoda and Tiris. Sonogram, we got that. Okay. Labs, which labs, Kagan? PT, PTT. All right, so these would be all the lab values, and it does say radiologic test. Red blood cells, D-dimer, fibrinogen, PT-INR, and PTT. So what is a D-dimer and what does it measure? The amount of blood, the amount of red blood cells per amount of blood. Presence of clots, which one? It definitely tests for blood clots. More specifically, it does rule out possible DVT or PE. So it does do that. Thanks, Vanessa. If it's less than 250 micrograms, then it's negative. If it's greater than 250 micrograms, then it's positive. So it just means it's a positive clot. They're going to still need to put all the pieces together before they go with just this here is only this one is a particular, it's either PE or DVT. So you would still be relying on your assessment findings. Does that make sense? So what does fibrinogen, what does that level measure? I'm going to get a fibrinogen level. What am I really looking for? How does fibrinogen play a role? In clotting factors, protein in the blood, okay. So okay, clotting factors. If there's a clot, the D-dimer will be high due to the increased fibrin. So if we have high fibrin levels, then we should be suspecting there's a clot somewhere, okay? All right, so what assessment would you do? Pedal pulses, assess for pain, check calf, okay, measure the calf. All right, neurovascular check, that's basically, can you feel me touching you? Can you wiggle your toes? And you would check pedal pulses. Blanching of the skin, vitals, warmth and obvious, and see if it's swollen. Okay, all good answers. Medical history, vital signs, and then any previous medical medication history, and then any previous medical history, diet and activity. So all of those are appropriate. Occupation, if you're on your feet 24/7, although we know most people can't do that, but if you're on your feet all the time, then this is going to increase your likelihood of developing clots. So what can nurses do to help prevent clot formation in their own legs? Because we're on our feet all the time, so we can wear compression socks, right? No one wants to have, cankles. Yeah, we can definitely move around, that's for sure. Elevate legs if that's available. We can do that. So what is the priority assessment for this patient? Circulation, okay. What else? Assess for shortness of breath, okay. Because we're going to be trying to rule out if there's any potential for complications. So would preventing an embolism be your priority assessment? So this is, what are we going to assess? Like your look, listening, and feeling. All right, so we're going to do ABCs, airway, breathing, and circulation, and then preventing clot formation by from becoming an embolism. So, you know, we could do leg elevation, we could do SCD, sequential compression devices, we could do TED hoses, you know, order those, so measure, get the appropriate measurement, and then get it, place them on the patient. Can a unlicensed assisted personnel person measure your patient's TED hose? No, they cannot. Thanks, Amy. Thanks, Israel and Michelle. They can't do that because now that's outside their scope of practice. Okay, so don't fall for that okey doke. If you've been doing it, then you shouldn't be. If you're a CNA or a patient care tech, according to the Board of Nursing, that would be out of your scope of out of their scope of practice. Should we put compression hoses on an arterial clot? No, we're not going to put compression hoses on an arterial clot. Okay, two different systems, they work completely different. What type of education does this patient require? So that she, remember, go back, she travels, long flights, not that active. So what assessment can we, or education can we provide? So keep moving, moving legs, diet, stop smoking. If so, chair exercises, they can do that. Moving, especially on the plane, frequently get up during the flight. All of those are good ones. So for this person, they're going to need hospitalization because they may need to fix it, or they're going to have to treat it. Potential surgery, depending medications and risk factors. So all the things to prevent themselves from being in that position. So even though it's not what's here, that's additional education that can be done. So these answers are not just a tell-all be-all. So I don't want you to think that you got it wrong. But frequently getting up, stockings during flights, the compression hoses, all of those are on point. All right. Questions about that? Any questions about clotting? Ms. Pritchett covered the hemophilia, I think, pretty well in sickle cell, right? Wrong? So thinking about it. So let's do a couple of case studies. Let me share screen again. Oops. And hold on, there's questions coming through. Hemophilia A. What's your question about hemophilia A, Kay Gannon? Okay, so Michelle, sickle cell gets its name from the shape because they become kind of crescent or S shape. So that's where that name comes from. Is this for an arterial clot, Will, or for venous? I'm wondering if that massage is kind of to loosen the muscles before the clot forms. So that's what that would be my thought process on that one. Okay, so you have hemophilia A and B, and A is 8 and B is 9. Okay. All right, looks like we got all the questions answered. Perfect. All right, so let's do the share screen business real quick. Or not real quick, but let's do the share screen. All right. So this is renal calculi. So we talked about that towards the end of the lecture. So let me make it bigger. Okay, there we go. All right, so we have a 58-year-old guy, type 2 diabetes, comes to the emergency department with severe right flank and belly pain with nausea and vomiting. Belly is soft without tenderness. The right flank is extremely tender to touch and to palpation. Vitals is written, so 142/80, heart rate's 88, respirations are 20, and he's setting at 99%. Positive hematuria on urine analysis. They started an IV line, 125 mils per hour of normal saline, and he's gone for an IV pyelogram, so an IVP, to confirm the diagnosis of a staghorn type stone in the right renal pelvis. The right kidney looks enlarged. So the patient states that he didn't sleep well last night and has not eaten much today. He's fatigued. Lab results are listed in the chart, and he weighs 277 pounds. So here's the chart review. So there's his labs. So based on the vignette, patient history, and lab values, what are your areas of concern in relation to a renal calculi, which is basically calculi is a stone, and then renal would be in the kidneys? The uric acid, creatinine, sodium, okay. Sodium's definitely high, but we're getting ready to give them more sodium, are we not? Because they have an IV line going. So this ALP is alkaline phosphorus. The ALT these are, and the AST are liver enzymes. So the last three here are all liver enzymes, by the way. Potassium level, it's 4, so it's cranking up, right? Anything else? All right, so let's see. What about his diabetes? Would that play a role, like with blood flow and things like that? Is calcium normal? Because remember, we have issues with increased calcium and increased uric acid stones, right? So let's see what's going on. So we've just kind of talked about the lab value concern. Glucose increases causes frequent UTIs, which causes kidney stones. Correct, Kay Gannon. So these are the reviews. Overall, things are within normal limits. We didn't even look at the BUN and creatinine. Let's scroll back up. We're talking about kidney stones. So we want to make sure the kidneys are working. So we have 30 for the BUN, and isn't that kind of either right outside the normal range? And then we have creatinine at 3.6. All right. And the glucose levels. The elevated creatinine and BUN can reflect renal damage or dehydration from the nausea and the vomiting. The glucose is obviously related to their history, but the stress will also cause the levels to rise, so we're not really sure which one's working here. So despite the nausea and vomiting and the assumed low PO intake, we still have an elevated glucose. Cholesterol level is at the top of the normal range, but addressing it at this time is not priority. So you just kind of make note of it, and then right now we're going to deal with the kidney stones. All right, so we're going to analyze the relationship between the creatinine and the GFR, which is the glomerular filtration rate, and the prediction of kidney function. So how do they relate? So how do they relate? What is your glomerular filtration rate? What is that? The creatinine shows how well the kidneys are filtering. Okay, I like that. Thanks, Ashley. So what is the GFR telling us? Nobody on the GFR? If the kidneys are doing their job. Well, it'll let you know it definitely, GFR is where the whole process of making pee begins. So we need that area to be functioning in order for the kidneys to filter appropriately. It does play a role with some of our other, vitals. However, in this particular case, we're looking at the effects of the kidneys being able to filter and work appropriately. So the creatinine is constantly, this is kind of the background of what creatinine does and its relationship and how it functions. So it's released by the muscle cells. The glomerulus and the intact nephron basically clears creatinine from the body as it's produced. So keeping that, therefore keeping the level constant. If we have a low GFR, then we're going to have an increase in our creatinine levels because we can't clear it. So the concentration or the creatinine clearance can be used to indicate changes in the function of the glomerulus. So here's kind of an equation using the serum to estimate GFR and a spot urine albumin. They'll do a creatinine ratio that urine creatinine ratio have replaced the 24-hour urine specimen that we talked about in class. So they have a lab value now that can give you a quick snippet of what's really going on. It doesn't mean that they will not still do the 24-hour urine collection. You still have physicians that'll do it that way. Yes. So that's how you know that the question came through. So when the GFR is decreased, the creatinine is increased. And the answer to that is yes. The goal of the glomerulus is basically to help clear the creatinine coming through, so to keep the level constant. But if the glomerulus is dysfunctional, then that means less creatinine is being cleared. If less creatinine is being cleared, we have it remaining in the blood system, which now means we have an increase of creatinine when we do lab values. And that's not what we want, because that means that our kidneys aren't working appropriately. Does that make sense? Okay. All right, so the pain is treated in the emergency room with IV morphine. It is late afternoon before the patient's admitted to the unit. They're scheduled to go for lithotripsy. What specific priorities do you identify? What is lithotripsy, by the way? Lithotripsy is a procedure for which
Thank you.
is it laser? Is it ultrasonic waves that help break up the stone? It's ultrasonic waves to help break up the stone. So basically, it almost looked like the machine isn't doing anything, but it's ultrasonic waves that they introduce to the abdominal area, and its job is to help, hopefully, from the tension of the waves to break the stones up. So, what will be our priorities? How do we want to? What do we want to do here? Ooh, mercy, no. So, yes, we're going to explain the procedure. We want to make sure they stay hydrated. Okay. Anything else? So, some specific priorities. Pain control. When they go, so basically strain the urine, check for hematuria. So, pain control, we want to reduce tenderness, reduce nausea, vomiting, control the glucose levels. So it can cause, because of the stress of the illness, the glucose levels can will become elevated. Facilitate sleep rest because they're pretty exhausted. Monitor the H&H because if we have hematuria, then we're also losing blood volume. Monitor fluid status and creatinine levels. So BUN and creatinine do indicate underlying renal damage. What problems are possible as a result of a staghorn stone? Damage to the nephrons or ureter, okay? What kind of stone is a staghorn stone? Is that a calcium oxalate stone? Is that a uric acid stone? Is it a cystine, a struvite? What kind of stone is that? Correct, Jessica. It's a struvite stone. So that usually happens when a patient has chronic UTIs. So the bacteria causes the urine to be more alkaline or too alkaline. Magnesium, ammonia, phosphates, those are all your kind of your causes. More specifically, magnesium, ammonia, and phosphate. That's what the stone is consistent of. So excess. Okay, so remember when I covered the different stone types? You have the oxalate, which is the most common one. The calcium oxalate that forms in acidic urine due to the increased amounts of calcium and oxalates in the urine. And then we kind of talked about how do we get increased oxalates? So the two of them, the calcium and the oxalates, usually bind together in the gut, and oxalate is usually excreted in the stool. So if you have any GI issues like ulcerative colitis, Crohn's disease, or any malabsorption, then it's going to have difficulty digesting the fats. So the calcium is going to bind to the fats, leaving the oxalate in the urine. So then we're going to end up with an oxalate stone. High intake of oxalates. So what kind of foods are high in oxalates? Do you remember? Prunes. Okay. Fries, spinach, animal protein. So rhubarbs, potato chips, nut butters, those are some more common ones. Okay. Bran. So those are foods that are high in oxalates that can predispose individuals to calcium oxalate stones. The other thing is if you're using soda as your eye opener, any kind of soda, so Dr. Pepper, Coke, Pepsi, those are all teas, caffeinated teas, those are all prone for folks to develop kidney stones. So other causes of calcium oxalate stones would be too much calcium in the body, so hypercalcemia, if they're taking calcium supplements with vitamin D. Hyperparathyroidism, because remember the parathyroid gland is making too much calcium, too much sodium intake. So we saw that the FF sodium was close to 144, right? So yeah, but your staghorn stone is going to be your struvite. Is that rare or is that common? A struvite stone. It's rare. What's the other rare stone? And this will be the one that has extra or too much amino acid. It'll be the cysteine stone. And it's directly related to the glomerulus. So outside of creatinine, it also clears amino acids. So when the glomerulus filters blood, the amino acids go to the Bowman's capsule, to more specifically the proximal convoluted tubule, where the majority of reabsorption of the filtrate happens. So 100% of the amino acids will be reabsorbed. However, if we're looking at a kidney stone, then the amino acids will end up crystallizing together to form a kidney stone versus being filtered out. Okay. The other type of stone is a uric acid stone, which usually forms when there's too much uric acid in the urine. So the pH would be low, so more acidic. That's why it's called uric acid. And usually what happens here, the glomerulus will take the blood, filter it like uric acid, which is a waste product of protein. Too much of it ends up in the body, collects in the Bowman's capsule, and it goes down through the renal tubules and crystallize with each other and develop kidney stones. So other causes could be gout or dehydration, which is low amounts of water in the filtrate. So the urine becomes more concentrated or more acidic and forms crystals in the filtrate. Another condition which this person has, FF, in this scenario, they do have diabetes type 2, so that can also cause your extra uric acid. So those are some things to kind of look at. The only other stone type would be calcium phosphate. So this makes the urine more, it forms when the urine is more alkaline versus acidic. More specifically in the renal tubules, it's an issue there. So the patient has an issue with the renal tubules and they will develop stones in that particular area. So stones can be anywhere where the concentration is high. So it could be inside the kidneys, it could be in the ureters, it could be in the bladder. So those stones can form anywhere in that whole renal unit. All right. So what problems are possible as a result of the stone? Pain, yep, blockage, obstruction. Good, good, good. So a stone can cause chronic infection. You can have a pelvic obstruction of, and not in your, but a renal pelvis obstruction. That can also cause the patient to have an nephrectomy, so the kidney would have to be removed. Chronic infection can lead to alterations in blood glucose and damage to the tubules, kidney swelling, permanent damage. They can have a complete obstruction. So that can affect the function of the proximal tubule and the glomerulus, which means our filtration rate is going to be diminished. Okay. So we're giving the patient garamycin, which is gentamicin. The pharmacist is going to calculate the dose, but you decide to double check with your calculations. How much will the patient receive per dose? And then after considering the results, what are your concerns? Because how much did she weigh? 277 pounds? Was that correct? Okay. So we need to convert that to kilograms, right? So she's 277, then we're going to divide that by 2.2. So that's oops. So she's about 126 kilos. So and then we'll multiply that by 6, which is 755, which Kay Gannon and Ashley got. So 755 milligrams per kilogram per day. Or 188 per dose. Because you divide it now by 3, because she's going to get 3 doses. Shouldn't it be 251? So if it's 755 per day, and she's getting it every 8 hours, then we would have to divide that by 3, because 8 goes into 24 3 times, and it would be 252 milligrams per day. I mean, per dose, not per day, per dose. So 755 per day and 252 per dose. Okay. Yep, you would round. All right. So here's the calculation. We came up with the same thing, 252 milligrams per dose. All right, so the recommended is 3 to 6 mg per milligram per kilogram per day if there are no renal concerns. Do we not have renal concerns? And if so, why? Why would we have renal concerns? Because they have a stone. What else? What would we look at to that would alarm us that the kidneys are having problems? The BUN and creatinine. Thanks, Ashley. So since we know that there's been some kidney dysfunction, should we be giving them the higher end of this dosage? We should be looking at the lower end. Okay, so because it's going to have difficulty clearing the kidneys. All right, so the ordered dose is at the max dose and has the capacity to be nephrotoxic. Renal function's already impaired, so by the elevated BUN and creatinine. So the dose of the aminoglycoside will vary depending on the patient's renal function. And if at all possible, we might want to stay away from ordering gentamicin if we could. But if we had to give it, then we want to go on the lower end and not the upper end. Okay? So one thing you might want to commit to memory as you're in your clinicals is that if you're dealing with, renal compromised patients and you see gentamicin, then you might want to, make sure that this would be appropriate, or this is the appropriate dose for that individual to receive that particular gentamicin or that particular medication. So there's other medicines to, if you're looking at an infectious process, because we don't use antibiotics to treat a kidney stone unless there's an infectious process. So they can use a cephalosporin to treat those kinds of things. Cephalosporin is a derivative of penicillin. Usually if you are allergic to penicillin, then they will shift over to a cephalosporin because it has less side effects. And there's like 6 or so generations of cephalosporins that can be used. And if you don't know what a cephalosporin is, it's anything that says cepha or cephta in it. All right, roll on down. So using SBAR to, communicate your concerns about the dose of gentamicin to your physician. What would you do? Any suggestions? Yo, doctor, your medicine's wrong. Would that be it? So basically tell them you have FF as your patient. They came in, when they were admitted with a kidney stone, give them the lab values, BUN is 30, creatinine is 3.6, right? And then you ordered garamycin or gentamicin, but it's at the higher end of the max dose. Would you do, based on her labs, she already has difficulty with the kidneys working properly. Do we want to cause nephrotoxicity? Can we decrease the dose or prescribe something different? So that's kind of it in a nutshell. So the one thing I do is identify myself, but here's the situation. Focus on the factors you have identified: risk for renal impairment, renal function, presence of the Staghorn calculi, kidneys already swollen, relate the gentamicin, the amount in each dose and that it's the max, and you would conclude your remarks with the recommendation to consult with the pharmacist so that the appropriate safe dose can be calculated. When the doctor reduces it to 1 mg per kg every 12 hours and orders daily creatinine and BUN levels, as well as a trough gentamicin level after day 2. You will monitor the patient for what signs of gentamicin toxicity. So select all that apply. There. All right, tinnitus, headache, any others? A, B, D, E. Why D? and YE. Is the patient restless now? They're primarily in pain, so if you fix the pain part, you should be A-okay, right? Okay. What was their respiratory rate? Was it 30? 20, so that's not tachypnea. Yeah. All right, so A, B, and actually C. Those will be your answers. What is a trough? What does trough mean? What does trough mean? Lowest point. Okay, so there's two medicines that a physician will order, a peak and a trough. And what the trough is measuring, there's a line of how medication should go when we're looking at the therapeutic process. You don't want something to be beyond therapeutic, because if it's beyond therapeutic, then it's toxic to the body. If it's less than therapeutic, then it's ineffective. So a trough measures the medication when it should be at the lowest point or have the lowest level in the body, but still be therapeutic. Okay, so if they're saying the therapeutic range for gentamicin is 17 to 35, that's your range. If your gentamicin level at the peak status, which is 1 hour after the medication has been administered, so if that number was 50, would we be therapeutic? Yes or no? No, we wouldn't. If the level was 25, would we be therapeutic? If the range is 17 to 35, yes. So what if your level was 12? Would you be therapeutic? If your gentamicin level, and this would be if we're measuring the trough, would you be therapeutic if your number came back and it was 12? Remember, the range is 17 to 35. So if I'm measuring the trough, which is the beginning, I want to know, am I still therapeutic when the medication is at its lowest level in my body? The answer to that would be no. So I'd have to at least be 17, 18, 19. I need to be there in order for me to be therapeutic. And when I'm looking at the low end, anything less than 17 is not therapeutic. Okay. So if you did that result on FF and it came back and it was 12, what would be your next steps? So if this is your patient, what would be your next steps? You need to contact the doctor. One or two things is going to happen. We're going to either increase the dose, right? Or we're going to increase the frequency. Those are your two options. So either they need to get it more often, so you would keep the dose the same, but increase the frequency. Or you would keep your frequency the same and increase the medication dose, but you won't do both. Does that make sense? Got it. Okay. I think somebody's out of function, so can you mute your phone? Because I just heard some clapping in the background. And I can hear the individual talking. All right, so tinnitus is the signs of ototoxicity, and those signs are or signs of your medication being toxic would be tinnitus, which is ringing in the ears, dizziness, and diminished hearing. Those are all related to hearing. And they can be irreversible, so that person can lose their ability to hear. Signs of neurotoxicity would be headache, dizziness, lethargy, tremors, and visual disturbances. So that's why you have A, B, and C. All right, so we're moving on. So you walk past the patient's room. Yes. The question was, can it cause deafness? Yes, it can. That would mean you would lose your hearing. So you would have nerve damage versus conductive hearing loss, or where you, like, if you have a bunch of wax in your ear. So that would be completely different. You'd have permanent versus temporary. Okay, so you go back by the patient's room. You notice the patient crawling off and off the end of the bed. What are you going to do? Patient safety, assess orientation status, okay. Stop them, got it. Check them for confusion. Okay. So as you help him back into bed, you tell him you could hurt yourself if he tries to get out that way. And then you're going to assess his pain level and orientation level. Ask him why he's trying to get up. Did he need to go to the bathroom? Lower the side rail to help him stand up at the side of the bed. Hold on to him and give him a urinal. You'll probably have to hold it in place. Make sure you have gloves. Return him to the bed, raise the side rails, and give him the call light and tell him if he needs you, call you. If he has family in the room, then ask them if he would like them to, or if they are in the waiting room, have them come in to sit with the patient. If he's a newly confused person, then you want to assess vitals and level of consciousness, get a complete assessment, notify the doctor if there's any changes. So it might be necessary to turn on the bed alarm just in case he tries to get up alone again. So radiology calls, and you'll tell FF that radiology called, and you'll let him know that what time his lithotripsy procedure's been scheduled for the next day. He's scared. What if it doesn't work? Will they do surgery? I can't do that. I don't have any insurance. This is costing me already. How will you respond? What would be the best thing to say? We don't have time to worry about your insurance problems. We need to make sure you get better. Would that be the right thing to say? Okay. Can we help him in any way? Are there any services we can consider that may help with this process? Okay, good, Kristen. Do you want to speak to social work? Check into emergency coverage. Exactly. So case management can help with resources, more specifically social work. You know, talk to them about the procedure, because that's another concern. All right, so tell him that, you know, that it is not, if it's not treated appropriately, he can end up with a kidney obstruction and with a long range effect on his health. He can't ignore it. The longer he waits, the more it's going to cost. That is true. Reassure him that difficulty with affordable health care is an increasing common problem, and that he will not be denied care that's necessary. And the hospital will also have a financial representative who can help facilitate payment options. We can still do social worker, because they usually they're able to find monies where the hospital representative may not be. So we've already talked about that. If he insists on leaving, then explain the consequences of signing out against medical advice, but make sure all of this is documented in his chart. So he decides to stay, do the lithotripsy, and it's successful. He goes home the next day, but before his discharge, he met with the hospital social worker who assisted him with applying for hospital indigent funding and available insurance plans. So I think we're done, at least with that case study. Questions about renal calculi, DVT, peripheral vascular disease. Yep, they do, and they do have patient representatives that will help. They're good about telling you if you can't afford it, they'll put you on a payment plan. They're good for that. But if he doesn't have the finances, you know, maybe he's underinsured, then or uninsured altogether, he's going to need additional assistance, and that's where social worker or social work is a really good process to introduce them to. Okay, so I don't think I missed anything. I think this was stuff we didn't cover on Tuesday. The only other thing I didn't talk about was post-operative surgical pain. I don't believe I talked about that. So outside of making sure that we have, or that our patients know, let me stop sharing, you know, that they can or need to utilize their PCA if they're on a PCA. What would be one of the critical assessments we want to do for a patient after they've come out of surgery? Excuse me. We want to do we want to assess respiratory status for sure. Vital signs, pain tolerance, airway, breathing, circulation, all of those things are things we want to do. So if your patient has elevated vital signs, but the vitals, and they're in pain, what do you treat? What's your concern? Elevated vital signs and they're in pain. What is our main concern? The pain. If we treat the pain, then the vital signs should resolve, correct? All right. Don't forget to look at your FLAC scales. We talked about that. I know it's in your book. It's in Lippincott. So don't just look over there. Oh yeah, FLAC. Know when to use it. When do you use FLAC scales? What age range? For infants? Okay, when the patient is nonverbal, but what age? I want to know age range. Any age, but mostly infants. That's when we'll use faces, right? Right, Jessica? Okay. When do you use the FLAC tool, the FLACC? When do we use that? Much older than infants. So Amy says that FLAC is in infants and faces is 3 and older. Are we correct? All right, so faces would be used if the child is 3 or over. So younger than 3, we're going to use FLAC. Does that make sense? There's a lot of quiet people. Okay. So why do we put NG tubes in people? The decompression, what are we decompressing? The GI system. What is our most definitive gold standard for NG tube? X-ray. Must have an X-ray. Okay. If a patient has thyroid problems, can they just stop their medicines if they have any thyroid or Addison's or Cushing's? Can they just stop cold turkey? Absolutely not. They cannot stop cold turkey. Okay. So they must keep going. What if you have a person that has Addison's and they're under extreme stress? Will we keep, what can we do for them, or what should we instruct them to do? Increase medications. So the dose would need to be increased to help balance the process. Okay. So if a person tells you they're sleeping, 14 hours a day, what endocrine disorder do you think they may have? Hypothyroidism, because they have a lot of fatigue. So go back and look at, when we talked about hypothyroidism, hyperthyroidism, one's cold sensitive, one's heat sensitive. So the more thyroid you make, does that speed up your metabolism or slow it down? It speeds it up. So that's going to be that person that's going to be heat sensitive, right? So you would expect all their vitals and everything to be elevated. If you have hypothyroidism, then they're going to be on the opposite end. They're going to have slower movements, cold tolerance, vitals will be low, they'll be tired. So completely different than someone with hyperthyroidism. Okay. So go back and I usually like to compare and contrast the difference when I'm looking at hypers and hypos. So the hormone's the same, the thyroid, the TSH, your T3 and T4. So the hormones don't change. What changes is whether there's too much or too little. And then know your Graves, what mixed edema is, and then your thyroid storm, what conditions do that happen under. So you still have to know what's the worst case scenario. If you give a person, say for instance, you have your Addison's person, right? Do they have hyper or hypocortisolism? Hypo. So in order to treat them, we need to give them what? What's our treatment for hypocortisolism? So we need to give them some cortisol, right? So, and corticosteroids. So if we're giving them corticosteroids to increase, levels, what would be the complication or the side effects that we would need to monitor for? Calcium levels in what way, Amy? I don't disagree. For osteoporosis, we look at their glucose, we look at their potassium. And so what signs, or where would you normally see those issues? So there was osteoporosis that came through potassium levels, glucose levels, mood changes, skeletal muscles. So we would be looking for signs and symptoms that we would see in Cushing's, correct? So when you're giving someone a correction of the medicine, then we would be looking for the opposite cause or the opposite effect. So they wouldn't have weight loss, they would have weight gain. So all the signs and symptoms you would see in a person who had too much corticosteroid, that would be the thing we would be looking for. Okay. Are your Addison's folks usually obese or thin? They're thin. So kind of how I'm asking you all these questions, that's how you should be studying for it. You know, what would I see? If someone had their parathyroid hormone removed, then they would be at risk for hyper or hypocalcemia. Hypo. If they had their thyroid removed, then we would need to replace their TSH and their T3 and T4 with what? So if their thyroid's taken out, then we need some type of thyroid replacement medicine like Synthroid. Okay? So I think the biggest thing I can tell you guys is before you answer a question on that test, read the question thoroughly. Don't wag it. That's wild ass guess what you think it's going to say. Okay? Take your time. Don't forget about the nutrition, the celiac disease, the, you know, appropriate lab values, the coronary diets, you know, the DASH diets, the ones that you would tell patients if they have coronary artery disease what not to eat, like organ meats. Know your lab values, know your percentages of carbohydrates, proteins, etc. So all those things we did back on day one, okay? You know, if I have celiac disease, you know, can I eat potatoes? Would that be appropriate? So celiac is potato gluten-free. So we can actually eat potatoes. We can eat potatoes, we can eat apples, they can do corn. They can't do wheat, rye, oats, barley. But they can tolerate corns, fruits, and veggies. Okay? So it's kind of those specifics. It's one thing to say gluten-free, but when you're telling somebody gluten-free, what's gluten-free? What are usually concerns with folks on PCA pumps? What is the patient's concern? That they're going to overdose and become addicted, right? Does that happen? You know, can that happen? Will it happen? No. I mean, it is, you know, there is a, if, when, there's a couple of situations where we will actually give some type of opioid. But, you know, in your sickle cell people, are we going to withhold opioids? No. So if they're having a crisis, we don't have time to be playing games. We need to give the medicine. Okay, so yeah, opioids does have a high rate of addiction, but rarely, you know, will they have an addiction in an acute process. Addictions happen over time. That's like long-term use of, you know, getting opioids like Vicodin and things like that. But in an acute phase, addiction is the least of the concerns. So someone coming, you know, out of surgery, they need that medicine. So we can, you know, if they're concerned about addiction, from a short-term basis, addiction doesn't happen. Okay? You do see more addiction and chronic pain. That is true. Anything else you guys can think of or questions you may have? There's 50 questions. There'll be some select all that applies. Not sure about math, but you know what? You know, if you had an I&O math question, okay. Um, from what I remember last year, which was last semester, we didn't do math questions unless it was pharmacy. It was a pharmacy question about the drug, like side effects and things like that. It wasn't not necessarily do a math question. But I don't know if if that's going to change because I'm not coordinator. Coordinator has final say. Okay. Give me an activity a hemophilia patient can do. Can they play basketball? Would that be a recommended suggested activity to do? No. Swimming would be a great one. Okay. What about what if they get injured? What can they do? What's that? How do we treat it? Golf. I mean, that you can do golfing, Altoin. Just make sure you're not in somebody else's way of getting hit by a ball. So I'm okay with that. That's a good one. Kristen said rice if you have an injury. So what is rice? Is that like brown rice? Basmati rice? Which one? So rest, ice. Let's see. Compression and elevation. Excellent. Excellent. All right. I mean, I think you guys seem like you're kind of ready. What do you think? Remember somebody goes, no. Remember your nursing process. You assess before you do anything. So, if your patient starts exhibiting some abnormal signs, if they're restless or whatever, then start assessing their vital signs and pain level, especially, if they came out of surgery, sickle cell, anything like that. But just remember what you need to do. If someone tells you to, list organ meats, what would be an example of an organ meat? So liver, heart, some gizzards, absolutely. So just understand that would not be something you would tell a person who's trying to lower their cholesterol, hey, eat a bunch of these. Kidneys, exactly. So, just think smart. Don't fall for okie dokes. Don't go looking for zebras. Don't let don't let the question chase you down the zebra trail and there's no zebras there. Okay. For types of practice questions to look at, I would say look at your NCLEX books based on the exemplars that you study. Does that make sense? So don't go looking at something that has nothing to do with the exemplars that we have not covered. So make sure you look at the exemplars that we have covered. Okay. One other thing that I can think of, and I don't know, I know I've talked to my students about that. If your patient has surgery and they're having a lot of gas pains, what can we do? Especially if it's belly surgery. What should we do for them? Give them some Gas-X? Get them up and moving around. Get them up. Once they start moving around, the gas will shift. They'll start passing a bunch of it, which will be good for the patient, not necessarily good for the aroma, but whatever. Okay. Know your enzymes and pancreatitis, which you'd be looking at and looking for. Know your interventions and your education related to things like PUD, whether it's gastric or duodenal, your pancreatitis patients, what kind of meals they can have, those types of things. What recommendations you can give to a person to help them with their cholesterol levels. So if they have high LDLs, what they can eat. If they have low LDLs, what they need to do. You know what I'm saying? Or if you have low LDLs, you're good. But if you have high LDLs, then you need to make some changes. If you have high HDLs, you're good. But if you have low HDLs, what can you do? So it kind of goes back to that nutritional part. Okay. All right. Other than that, I mean, I think that covers it. Yep, H equals healthy. That's one way to look at it. If you're trying to remember the difference between HDLs and LDLs. Yep, the LDLs are your lousy or low lipid density proteins, and your HDLs would be your high lipid density proteins. Okay, you guys got this. If you've been, doing the raising the bars, I cannot see you not being successful. So if there's no other questions, and I'm gonna conclude it, I'll post it to the YouTube channel. You'll see some other videos that I did from last semester for at DCCCD or DCCCD space J2. All right, see you guys on Monday. Have a good weekend. You're welcome.